Now I would call our next speaker, Dr. Ayesha Kamal. She's a professor of neurology and stroke specialist, director stroke fellowship program at AKY. Her topic of talk is stroke care challenges in Pakistan.
So today I'm going to talk about the local story, and what I will talk about is of course what the challenges are, and to some extent the kind of work that our team's been doing for the past, I would say, 8 to 10 years to sort of try to find some local solutions to the problem as well, not just its challenges but some of the responses. One thing is really clear, and this message actually isn't getting across as much as I would like for people who are making decisions to see, is that non-communicable disorders like strokes and heart attacks and MIs are becoming very important reasons for morbidity and mortality and sustained disability in the developing world. It isn't just mother and child care and anemia and diarrhea. I mean, there's no point saving families when they're, what happens when the working member of the family is put out. You know the devastating effects this has in cultures like ours, where 40 and productive is a very important thing. And it's becoming increasingly important that all over in the developing world, wherever the low-income countries are, they're bearing 80% of the burden of NCDs. And this is a fact that is recognized, but it's interesting to me that little really is being done about it in very real terms, which I mean, where is the money, really? So that's important. Now, what do we know about Pakistan? We know that actually the prevalence of stroke may be as much as a quarter over the age of 35, and we do incredibly sensitive questions. We've gone out in the community and why is this happening? So we've gone out in the community and asked very sensitive questions about the presence of the symptoms of stroke. And we've shown people pictures about how is it to experience a stroke, because our population is not necessarily literate. And that's a lifetime prevalence where they say yes to these very sensitive questions about hemiparesis, visual loss. This is the kind of problems that they're saying yes to. And that is surprising. Men and women are equally affected. So there is no protection for the estrogen that we generally assume. And we always assume that it will be the older lady with AFib who's going to get a stroke from AFib. This is not the case in Pakistan. Everybody is already equally affected. And perhaps the reason for this woman being equal is my colleague in gestational diabetes, and she says this is the gestational diabetes which is already raising the risk because they turn into diabetics earlier. 1 in 3 is hypertensive. 1 in 3 adults is already hypertensive. 1 in 4 is diabetic. That's a lot of sick people, a lot of modifiable risk factors right there. The other emerging risk factors are the rising rates of depression and suicide and common mental disorders in Pakistan, which are highly underappreciated and not treated. And we don't even have, now we're getting to have questionnaires to sort of start screening this regularly, because they also raise the risk of stroke and heart attacks, and they also raise the risk of risky behavior that leads to these diseases. So they're very important mechanisms. One of the most common mechanisms we have for ischemic stroke, at least, is intracranial stenosis, perhaps because we have a very diabetic population, and also because intracranial stenosis is related to inflammation, and because of the infections that we have while growing up, I think this is also a very common mechanism. This is what we learned about the epidemiology. What we've also learned out in the field is how to reach some of these people. This is one of the second studies or third studies we did in the field, and I got a phone call from my field officer. She said, I'm taking a picture of this kid and he's taking a picture of me. And he said, well, that's how we can reach them. And it's very interesting. We don't just have simple mobile phones in Pakistan. The Q mobiles and the other companies are even getting Android technology to places where we can go, maybe, but our phones and our thoughts can reach them. So the kid smokes, okay, this kid smokes, but he has an Android. And this is how we get to their minds, and this is the game of changing minds. That's the game we're in. We underappreciate. We always say, well, why did stroke happen a decade earlier in Pakistan? There is nothing very magical about this. Here's the facts. You see this kid over here? Do you see what she's got here? This is a hookah. This kid is smoking. And that there is a baby. And she's passively smoking. So this baby is 6 months old. These are the kids. She's smoking and the baby is passively smoking. I don't think we really underappreciate the risks of what's happening and where it's happening on the ground until we take a walk through Pakistan. This is where the targets are. Now, having said that, and having seen that, what we are, the next 10 years or hopefully for Pakistan is to try to move into these fields and get into the minds of these people through their phones, regardless of rural disparity or geographical disparity. We have 92% internet coverage and we have a national database, unlike any in the world. So this is the next steps, but I'm wanting to excite you here before I tell you the other challenges. So one of the biggest challenges is, and Craig said it very nicely when he put a box there and said what we need to do is at least implement what we know. The science is out there. No one's taking any advantage of the science of the first world. So what we said was, if you have a stroke and you want to do secondary prevention, what we would really like to do is make them take their medicines. I mean, if they ate their medicines and because they don't feel hypertension or whatever, why not give them a message to take their medicines? And what we did was that on this trial of patients, we tailored the message to the medicines that they took and the risk factors that they had. So not only we would tell them about the messages, we would also SMS them at the time they were due to take their medicines and say, have you taken your medicines today? If yes, do let us know. So we got a message back from a patient because they loved it. They said, have you had your 11 a.m. tea today? If yes, let me know. And so we started interacting and make them take their medicines. Another thing that we also did, by the way, is that these are not just KT. So knowledge transfer messages don't work. We are a very fatalistic population. We're not afraid of death or dying, and that doesn't work in our culture anyway. What does work is enhancing a sense of vulnerability and disability. Nobody likes that in any culture. So the words that we use in these messages, they are actually psychologically designed messages to engender a sense of vulnerability and also at the same time a sense of efficacy that things can be done about this. This is not KT. This is not knowledge transfer. So for this trial, when we started sending customized health messages and medicine reminder, we checked their adherence after 2 months of intervention on top of whatever the usual cares are at AKU. And we saw that the people in the intervention arms became better at taking their medications. The softer effect is what I saw in the clinic is that they were more comfortable about talking about their medications as opposed to those who did not receive that intervention. We also know that we have very high volume clinics. Anywhere in Pakistan, you do not have the time to talk about lifestyle changes or medicine adherence. I don't know about you guys, I certainly don't have the time to do that, and I always feel I kind of cheated on them. So this is also a way to establish your space in their mind space so they can actually take their medications without actually being there. So this is just one little study, and that's where we started. It's got an interesting background. The software that we're using for this is entirely free. It's called Frontline SMS. So this is also, it's not very expensive to use this. So the feasibility of these interventions is great. Frontline SMS was made after the Kashmir earthquake. And now we're using it in a sort of a peacetime situation. Now, I think we have to step back a little bit and look at what is the system, what's the context of our interventions. The healthcare systems over here, we are very acutely responsive. So when we have a measles epidemic, we respond to that. We have a dengue problem, we respond to that. We have Nigleria, we respond to that. We don't have a single comprehensive rehab center. There's no place where you can be an inpatient rehab. So one of the challenges we face, besides the lack of knowledge, which I just alluded to, is that we don't have a chronic care continuation program or midway house. All of us are trained here in Pakistan from different healthcare systems, and we say this, once you have a stroke and you're out there, and there's very little support. So we explored the potential of using MHealth to support the families and the stroke caregivers and the stroke care survivors through this gap. It's a real hole. And we know from our studies that at least 65% of stroke survivors, at least report one stroke complication in their first year after discharge. This was just a very old study, and we wanted to follow up on their quality of life and see what we could do. So what we designed is a movies for stroke program where we show very detailed movies. And we wanted to do this in a trial fashion because the kind of information that we are now sharing and the level of information that we were sharing with the stroke survivors and their caregivers is almost a training program for a nurse practitioner for stroke. So this is not very simple knowledge. Yes, there's simple knowledge, but it's about NG tube care, avoiding aspiration, responding as a first responder to CPR. That kind of knowledge, we wanted to make sure we were not enabling something with knowledge that could turn out to be disabling in the end, and that was our concern, and that's why we did it as a randomized controlled trial. Our primary objective was actually to achieve blood pressure and sugar control, and our secondary objective was to look at severity and disability. And this is how it really looked like. We didn't just show videos, we would do a pre-test and a post-test questionnaire after the video and see if they actually understood what was going on, and they had the idea. This is a video of a CPR, which by the way we showed a woman doing deliberately. And what we then did, and I'm going to try to really show you why what was important is that these are the kind of families that we helped. These are not very rich people. I want to jump to the results. We did not achieve our pre-specified primary outcome in terms of lowering blood pressure, sugar. People didn't become any more compliant than they could. But what was an utter surprise for us, by simply showing people movies on how to survive, what really happened was they stopped coming to the hospital. They stopped aspirating. They started doing exercises. So they changed in a year. They became functional. They became more functional than people who got the standard of care at AKU, which is still a standardized stroke service, standardized follow-ups, all the knowledge that you get. They just stopped bouncing. And they stopped bouncing around and getting sick, and they started getting better. And then if you look at how many people started getting in the modified Rankin score 0 to 1, that just kept getting better and better, and this was consistent. And across any which way we looked at functionality, it got better. And to me, I think that it's interesting that, we didn't make them any more compliant on blood pressure, and I think the reason was that this intervention was rolled out over 4 weeks. So by the time we got to the part of being better at secondary prevention things, they had already achieved. They were not very interested in that part. The control arm was also doing very well because stroke's a very serious disease, and once you get it, people take meds. The other part is that when we do trial design, sometimes we can't do dirty interventions, because what we wanted to see was, well, how do they get better? And our intervention, we didn't do any SMS reminders. Here is a knowledge transfer intervention. We didn't want to make a kitchen sink sort of intervention and not know which of our mechanisms were working. By those two separate trials, what we figured is, if we want people to do medication adherence, we've got to keep getting in their faces. Did you take your meds? And then make them have that habit and kind of withdraw. When we want to teach people skills for life, not to aspirate, we have to teach them separately and differently. And if we want to teach them both, now we know how both these interventions work, or when they don't work, we have to then give a combined intervention. And that's how I sort of parse it. I figured out that, it might be that this would be the most important thing we would achieve, and we wouldn't achieve those other things. Talking prescriptions, sorry for the, bolta parcha, bolta means to talk, parcha means a page. Talking prescriptions was something else we did after this, and this study was inspired when in a 50 patient clinic, the patients keep coming back to you, showing them your prescriptions. Hey doc, I've got the prescription. is this what you want me to eat? And then I saw Harry Potter, and in Harry Potter they show that film where everybody's talking. And I said, why can't these prescriptions talk to the patients? Why am I doing all the talking? So what we did was, what our team did was, again, we were inspired by the whole idea of getting into their faces. And what we also know, again, is the context of our intervention. This is a real prescription from a real patient. I put his medicines out on a bed. There are 14 medicines for this one patient. And some of them are, if you can see, some of them, I've bunched them according to a statin and antiplatelet. Some of them are the same. And that's because we have no control in Pakistan. So paracetamol is registered under 1,400 brand names in Pakistan. So if we want to be rational, we need to rationalize the user. We need to empower the user for this challenge. This is a great, serious challenge in Pakistan, and drug prescription for strokes are complex. So this is real. I always thought that why is it that our quacks and alternate healers are better than us in terms of intervention? The quacks, alternate healers, and hakims, they seem to be doing a better job in communication than us. And I think that's why I said, well, A, they're dangerous. We need to empower people with just straight off knowledge of what will make them, what prescriptions work for them and what not. But we also need to be better communicators. We could learn a few lessons of communications from these guys. And for instance, all medicines, it's like candy. They're available anywhere. Anyone can go and get any candy. Except for morphine, you can pretty much get everything in Pakistan, and that's because of the drug laws are very strict here. Time for prescriptions to speak is now. We thought it was high time prescriptions started speaking to patients. Now this is the first ever that we did. We've already advanced this software. Basically, we have a sheet which is an optical recognition sheet, the kind of the sheet that you have when you give exams, international exams, which goes to a server, and the sheet tells the server what messages need to go to the patient. And so when the patient leaves and we send this message, they will start getting IVR, robot calls, which tells them what their medicines actually do. The language, this entire program was designed in Urdu. First off, we didn't actually even try to translate it. It was a priori, this thing. And this is what we did to the intervention. We had daily interactive voice messages, text messages which followed from the voice messages, and weekly reminders for this, because we wanted to get this in their heads, like you need to do this, blah, 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 blah. This is what your medicines do. This is what your medicines actually do. Things like don't give your medicines to your neighbor, for instance, was also out there. The control received the standard stuff. This is the kind of messages that went out. And that's the details on the IVR call. So you could, if you forgot, we have an analysis of on the server that we are monitoring what was the most liked option. But this is the options that people had to see what they would like, and usually they would like dosage and frequency. They would like to know how the medicines work. So this is the kind of stuff that was available to them at the press of a button, and would talk to them. By the way, there was no. If we had a deal where what we can do is, once we have a deal, because of the low cost of SMS and cross transfer, you can hear it as many times as you like, and repetition is good. Repetition is good when you have a stroke and when you have a family taking care, and the caregiver may change. So repetition was good, and repetition was free, and it didn't cost us any extra for the repetition of these messages. So the primary outcome interest was a 3-month adherence measure. And when we looked at, this has also gone off for publication. I want to just go up to the results of the mean group. And what we found was that there was a difference in medication adherence, but we did not achieve statistical significance here, which we feel happened mainly because this is an very early stage trial. And when we go out in early stage trials, one of our challenges has always been to maintain continuity when you're doing complex care patients traveling all over Pakistan. We had a control line And that co-intervention where people could call the control line for any questions, raise the, just that simple interaction, we feel with the physicians, raise the level of care. Just a control line, that co-intervention shifted this. Also that at baseline these people were unusually adherent. But that's what we wanted to do. We wanted to first test the best case scenario where everything is standardized and see how much this achieves. This intervention is likely to achieve a lot more where there is no care like AKU. This is the reason we feel that this happened. And if we hadn't given any control line to usual care, I think we would have just lost touch with a lot of people. So this is where we are. And of course, if we had taken this intervention for another 6 months, we could have seen very meaningful differences. And that's the next step, really. This is where we want to go. One thing, though, is that the CVA patients did better than the cardiac patients. And I think this happens because in the game of adherence, if you have a serious disease, you're very serious about following through as well. And they did better. When we talk to our patients, the patients really appreciate this kind of knowledge. They don't want, whenever we pull out, when a trial closes and we pull out a service, patients don't like that we pull out the service. They keep saying, where's that line, where's that service, that used to help me, what about that reminder service? It's like they want it and they are following this. I think another thing which we've done very quietly is that there are certain health literacy myths and there are certain health literacy facts, which some of these myths are deliberately perpetuated for financial gains. So for instance, there is this feeling that certain brands are better than others, whereas certain generics may work just as well as others. Even local generics may work. And we have been talking about that in our IVR course. We've been telling people that, you don't need to pay so many thousands of rupees extra because you have been told by X, Y, or Z, or media, or whatever, that this brand is better than the others. And so there's this silent sort of revolution that's happening, which I think is in the end benefits the patient. It's a fee-for-service system. I don't think people deserve the truth. So one of the things the patients have told us is they love the daily reminder message. Seems to be they don't get very upset about it. They want more guidance about generics. They do not want to believe in the brand issue anymore. And they wanted us to have this app talk about not just their vascular meds, cover all the meds, the way that you've covered our vascular meds. And so this is the next step that we're working on. What I think I'm concluding is that yes, we have a lot of challenges here. We have a very high epidemiology and a very at-risk population, no doubt. We need to take the 1A, at least take the 1A class evidence that's out there and make people implement it. Despite the challenges, I think what we have here is also the ability to make great change because of the way the telecommunications sector is in our country and how much access we have to these populations. There are some things, certain interventions I didn't talk about. For instance, we've made a device where we can non-invasively measure these blood pressures and glucoses and lipids and things like that out in the field. We're working on certain software for community health workers, where with the government of Sindh, we could hopefully soon see if we can go in there and help them be better at interacting with the patients at the community level. So there are these things that are coming down the pike, but they're not, I don't have the data to show you right here and right now. So I think that's a wrap. Are there any questions?
Well, congratulations on all your fine work. You're certainly a leader in this area, and obviously the opportunities in Pakistan are enormous, as you've emphasised. So I just have two questions, if I may. I guess the first thing is, moving in the direction that you're doing, you do need to be reassured about effectiveness, which you're doing. And the problem with adherence is, what's the gold standard? And the Marinsky scale, which is a self-opinion, is maybe not so reliable. So it's always nice if you could get a biomarker, so something in the urine or blood pressure or something like that, and whether you've got some reassurance there. And then the second thing is the scalability of it all. And I guess it's, moving it from an academic exercise to something that's more sustainable, and whether there's any opportunities for any sort of commercial endeavour, or do you think that patients would be willing to pay a small fee for just to support the infrastructure and scalability of it?
Thanks for both of those. So this Moresky was chosen at least for these pilot trials because it's been validated here for its reportability. It's a validated scale of how much. But having said that, of course, there's reporting bias, and it's certainly not the best. With complex prescriptions, say if we did more than an antiplatelet and a statin adherence, and we wanted to measure that, we looked at those electronic pill openers, and then we can record those. And because of the number of pills, that becomes, because if there are more than 3 pills and they take one, it still doesn't tell us whether they took the other. We really, the team's been sitting around trying to figure this mess out, because we like to have even better measures. Now there's another way of doing it via MHealth itself, which is really interesting. It is called, so teenagers have this app called Snapchat. And you snap it and you can see whether they're taking it. And so what we do, we're looking at in the next set, is something called unannounced pill counts. So we have a base of how many pills they take and they go home, and how many blister packs they have. But they're not told when the Skype call or when they're going to be called. And then they're called on, and you take a video and you do an unannounced pill count and see how many pills actually went in. And this all can be done by the phone technology, which again reduces, you can reach out to like 5,000-6,000 people. You just have 2 operators doing this. It becomes very feasible. So we're leaning in the direction of unannounced pill counts. In terms of, urine biomarkers and things, if the medicine in their system, again, we could get one, or a platelet inhibition, we could get that. But I think it would be really interesting is to go for hard markers. Like, do you actually, so if they're taking their meds, it's safe to assume they would lower their pressure. And the harder, or if they're taking their cholesterol meds, they should be lowering their cholesterol. That would be, I think, data that the clinicians or those who make policies could be swayed by. So I think the next design, and the protocol, everything's written, is that to take a harder, clearer marker, exactly what you're saying, exactly, to prove that it's not just adherence, but it's effective adherence that results in outcomes that make sense to clinicians or investors or policymakers. That's where it really would make a real difference. I think the second question is also very interesting. What do you think is going to happen when you commercialize it and say, okay, we have this, and what's the feasibility of that? I think that's actually quite feasible. The reason is because people don't have, at least, I can't say for other contexts, I do understand our context, is that patients do not have the kind of interactions they need with their caregivers. So if I regularly see 55 patients every Wednesday between 8 to 2 p.m., 3 p.m., in which my average patient interaction time is 3.5 minutes. Clearly, they need more time. And they would be willing to pay for the kind of knowledge that they're not getting in that interaction. If it was institutionalized and made easy for them to access it. So if you're going to get a medical prescription, you can add the way that we are seeing it is to sell it as an e-prescription. So you get an e-prescription. It's been tested. If your movies are your e-prescription, on the day of discharge, we put that software in your phones. And by the way, we do all our studies with dyads. We never just do it with the stroke person themselves because they're older. Maybe they're not that comfortable with the technology. But we have joint families. So we have a younger, more savvy, tech-savvy person putting that into their phones and then teaching them and unrolling out that e-prescription from the point of contact. I think it'll be definitely more feasible for secondary prevention. I don't know about primary, like people of course feel very invincible until these things happen. Just like you said, these things are silent. So that part I don't know how much, but definitely when these things happen, people become very compliant and they'll take all the knowledge they can get at their fingertips.